The last tumor agnostic indication came about for RET fusions in solid tumors. RET fusions are extremely rare. They're present in about 5 to 10% papillary thyroid cancer and 2% non-small cell lung cancer. But outside of these, they are extremely rare in other solid tumors. We had previous approval of 2 RET inhibitors for papillary thyroid cancer and non-small cell lung cancer. And then so more recently, we've seen approval for solid tumors outside of these 2 histologies. There are multiple fusion partners, and the best way to test for these is RNA-based NGS testing. It's superior to DNA-based NGS testing, and IHC and FISH are poor. Their sensitivity and specificity varies depending on the fusion partner, so it's really not an accurate way to detect for these fusions. So both pralsetinib and selpercatinib were evaluated in tumor agnostic fashion in solid tumors. One was in a phase 1/2 ARIS study for pralsetinib with a response rate of 57%, with the albeit lower, modest PFS at 7.4 months. Selpercatinib, which led the study that led to its approval for tumor agnostic purposes, in September 2022, with the use of selpercatinib across various tumors, primarily pancreatic ductal carcinoma and colorectal cancer. These were both histologies with the bulk of the tumors that were enrolled in that study, showing a response rate of 44%, a more impressive PFS, almost a double, 13.2 months. And so these responses tended to be durable. But when you look at histology by histology, we can only look at the 2 main ones, colorectal cancer and pancreatic ductal carcinoma. We see that the response rate for colorectal cancer is about half that you would saw with pancreatic cancer. And again, this kind of opens the question of these RET fusion positive colorectal cancer, just like I've shown you that NTRK inhibitor or NTRK fusion positive colorectal cancer at baseline, if you test the tumor at time of diagnosis, these tend to be RAS wild type, and BRAF wild type tend to be MSI high. But you don't really know what happens with these tumors over time. Are these tumors, these are BRAF and RAS wild type, they're being treated with EGFR targeted therapy, or these acquiring mutations activating MAP kinase signaling, leading to resistance. Therefore, you see lower efficacy with RET fusion inhibitors. And to that point, there was a study that looked at various mechanisms of resistance to selpercatinib in non-small cell lung cancer, thyroid cancer. In that study, they used longitudinal cell-free DNA analysis, but it also looked at tissue. And what they saw for thyroid and non-small cell lung cancer is that on-target resistance, these solvent mutations, solvent front or hinge region, do occur. But these are minority of mechanisms of resistance to selpercatinib. Pralsetinib and selpercatinib were designed to overcome gatekeeper mutations. So gatekeeper mutation is not a mechanism of resistance, but other mutations can occur. That's common. These are the on-target resistant. But by and large, the main mechanism of resistance was bypass signaling activation, primarily MAP kinase signaling activation through various alterations that would occur. These tended to be polyclonal. And if you looked at tissue only, you could miss those. So these sometimes co-occurred as well with solvent front mutations for some patients, like in the figure on the last, the G figure, showing that multiple mechanisms were operating at the same time. So if you do tissue only analysis, and if you do tissue at the time of diagnosis, you're going to miss those. And those will tell you if you have an already pre-existing KRAS mutation response and you have RET fusion positive colorectal cancer, your response to selpercatinib maybe lower than if you didn't. Again, within that same process, this was an interesting study where they looked at BRAF and KRAS wild type. 96% had no alteration time of diagnosis. A large majority of those received EGFR targeted therapy, and they had patients that had metastatic colorectal cancer. Forgot to point this out. And when you track them over time, these patients can develop fusions, RET fusions, NTRK fusions, BRAF, FGFR, etc. And those patients, when they develop these fusions, they also tend to harbor subclonal alteration in MAP kinase signaling players, leading to potentially innate resistance if you were to use this RET fusion inhibitor therapy. So at the time where you develop that, you're also developing these subclonal alterations that are primarily adaptive in nature after following treatment with EGFR targeted therapy. And in this last section, we're just going to cover briefly some issues related with tumor agnostic targeted therapy. So there are three key issues with tumor agnostic approvals. One, the biologicals. From the biological standpoint, we're making a guess that this, provided that we find a specific alteration, that targeting this alteration would lead to the same efficacy irrespective of the histology. So there's a histology independent mechanism of action, and that there is no histology specific mechanism of resistance. So if you use that, the resistance is going to be the same. The mechanisms of resistance are going to be the same. And there's no one mutation that may have primary resistance to this targeted therapy. And this is very an estimation, because we don't really know, because these alterations, when we select for them, there's quite rare. So we sometimes don't have a sufficient number of patients to be able to look as whether there's difference in histology when it comes to resistant mechanism. And I've shown you over and over with colorectal cancer, whether having these alteration and MAP kinase signaling may be associated with lower response with NTRK inhibitors or RET fusion inhibitors in colorectal cancer specifically. There are also statistical consideration how to design these trials. There's a lot of heterogeneity in these trials, how to correct for type 1 error in these studies, how to choose the best biomarker. Response rate is chosen, but having a high response rate does not mean that it's durable. And some regulatory issues, will touch base on that in the last slides. So biology matters. For example, the poster child, BRAF mutation, colorectal cancer, BRAF inhibitor with monotherapy and combination MEK inhibitors did not work. This is because they will have activation of this MAP kinase signaling. So we need EGFR inhibitors to overcome resistance. Same for sotorasib, adagrasib in KRAS mutant colorectal cancer. Data in colorectal cancer was substantially worse than we've seen data in lung cancer. So again, this has been looked at now in combination with EGFR inhibitor therapy. So there's a difference in these signaling occurring colorectal cancer as to occur to other tumors. And similarly, with fusion positive colorectal, be it NTRK or RET fusion positive, we may have activation MAP kinase signaling, particularly under the selective pressure of treatment with EGFR inhibitors, which may lead to lower efficacy, the lower response rate that we've seen with RET fusion, and also the lower response rate and lower, PFS compared to other solid tumors that we've seen with larotrectinib and entrectinib. So these are the data from larotrectinib in GI cancer. This was, I think, presented in ESMO 2022. And you see PFS of 5.5 months, which is very comparable to what we would have with cytotoxic chemotherapy in second and third line setting. Again, as well, I've been showing you with the entrectinib trial, and I think it was also presented ESMO 2022. The difference in response rate was substantial across GI cancer, pancreatic cancer 75%, 20% colorectal cancer, and the PFS was even lower for colorectal cancer, is about 3 months. So the demonstration of histology-independent activity without looking at resistance mechanism limits generalizability. And sometimes you're not able to do these studies because, these alterations are so rare that you're not going to have a sufficient number of patients to test for this. And when these tumor agnostic trials are designed, they're not really designed to look for these mechanisms of resistance to be able to tease out whether that happens in that histology or not. Often, the trial does not have embedded biomarker analysis, or they're using archival tissue to look at the full mutational spectrum or immune profiling. And then there's lack of we're not testing cell-free DNA because, as I've told you, if you do only tissue NGS, you may miss these subclonal alterations. And if we look at post-approval data that are exploring mechanism of resistance, because of the numbers, we may be limited to data from anchor malignancies, the malignancies which have high prevalence of these alterations, but no data in the tail malignancy, the very few malignancies that are within these tumor agnostic trials. How do we define clinical efficacy? We know we use overall response rate, but response rate 20% means something in one tumor, and that does not mean the same in another tumor. We don't really know how this alteration affects prognosis. So if we look at, for example, NRG1 fusion, non-small cell lung cancer, they're worse prognostic, they have worse prognostic value. We don't know if it's the same for very rare tumors where we can detect this NRG1 fusions. So we don't really know what to make of that response rate. Are they going to do just the same with cytotoxic chemotherapy or worse? And you need certain numbers of patients to be able to make that determination. Again, if the response is not durable, it doesn't mean anything. We've seen that with sotorasib and KRAS G12C mutated non-small cell lung cancer, great overall response rate. But when it came down to comparing it to standard of care, versus docetaxel second line, the PFS data was just very, very modest. And how to design these tumor agnostic trials, how many patients should we include in each cohort, how many tumors should we include in these trials, how to correct for type 1 error, because these trials are fraught with type 1 error, and you have to, because of multiple comparisons, multiple treatment arms. And then when we do these conditional tumor agnostic approval with follow-up studies are necessary to determine efficacy, we don't really have high quality data. We just have these expanded cohorts, and we're not really, with the exception of a few anchor malignancy, we're not really able to compare that drug to standard of care. And obviously, the difficulty of designing these trials when you have all these regulatory agencies that vary in their threshold to determine what is, what the evidence that we would consider as valid when it comes to tumor agnostic trials. Last slide, regulatory consideration. What happens when the survival data are lackluster, when the biomarker doesn't really pan out? We've seen that with TMB. Are they going to withdraw the approval? What happens if the phase 2 trial evaluating efficacy in an anchor malignancy, not the tail malignancy, does not show benefit after accelerated approval? Are we going to extrapolate this to all other tumors? We're seeing that it didn't show efficacy in the anchor malignancy. Would we need to modify this, for example, approval, say, for example, in gliomas, if you have TMB high and they do worse with immunotherapy, and even in CNS tumor, if they're MSI high, there are data showing that they have worse outcome. Should we make some exceptions based on the data that would come, and what number, what quality of data do we need? Companion tests are not necessary when non-proprietary assay with high level of accuracy are available. But for example, we're shifting the gears from tumor agnostic fusions or mutation where detection of this is quite accurate to more tumor agnostic therapy directed against any level of HER2 expression. And HER2 expression, for example, is very heterogeneous across tumors. So when we do a HER2 low basket trial, did we validate this HER2 expression among classically tumors where we haven't really treated with HER2 targeted therapy? And how do we model cost-effective analysis for tumor agnostic therapy? Who pays for that, and based on what modeling analysis? Because historically, we need survival data to tell you whether treatment is cost-effective or not. So this huge regulatory headache for tumor agnostic therapies. And with that, I conclude this presentation.